when we would look at the data and look at where the spend is going from a benefit standpoint, billions of dollars annual healthcare spend at both employers. North of 80% was attributed to medical spend and pharmacy PBM spend. So that's really where I'd concentrate. I'd say the majority of my time and effort and focus towards trying to unlock and unpack ways of working better with our vendor partners that we had, as well as looking at creative, innovative pathways forward.
Welcome to Broken Benefits. I'm your host, Lee Lewis, and this is a podcast where we learn from top employer experts on how to fix our broken benefits to save lives, save dollars, and save your talent. Welcome back, everybody, to Broken Benefits. I'm your host, Lee Lewis, and excited to bring in today's guest. Today's guest, Jason Parrott, ran benefits for both a Fortune 10 and a Fortune 30. He ran benefits for the largest telecom company in the world, the largest aerospace company in the world, managed during his tenure tens of billions of dollars of healthcare spend, and each year at both companies was helping to oversee well over $1 billion of healthcare transactions, healthcare spend, and services. He evaluated over 300, 400 companies during any couple of years while having these roles, and also helped to usher in probably the most sophisticated employer to hospital direct contracting platform and activity that has existed anywhere among the absolute giants in American industry. And so we are so excited to be able to learn from him today. Jason, welcome to the show.
Thank you, Lee. Pleasure to be here.
Marvelous. Well, hey, just kind of starting off, you had an incredible career over decades at these completely storied, multi-century old companies. Tell us maybe some of the, a couple of the highlights of some of the most rewarding things that you were able to do in your career.
Yeah, I would say, first of all, we had stellar teams, really at both of the prior Fortune 10 and Fortune 30 employers I was at. So no one individual can do everything, right? It really requires a really cohesive team. And, I had the privilege of working with a lot of brilliant people that I learned from, that mentored me, and, certainly really enjoyed, I'd say, the camaraderie with all that. So that's number one. Number two, when we would look at the data and look at where the spend is going from a benefit standpoint, billions of dollars annual healthcare spend at both employers. North of 80% was attributed to medical spend and pharmacy PBM spend. So that's really where I'd concentrate. I'd say the majority of my time and effort and focus towards trying to unlock and unpack ways of working better with our vendor partners that we had, as well as looking at creative, innovative pathways forward to unlock greater value.
Everyone, now just a quick word from today's sponsor. As you think about that, or let's take medical spend for a moment, how would you approach developing your strategy each year around medical spend, both in terms of inputs, what you wanted to do, and then how would you set goals?
Yeah. We would take a 5-year forward-looking view actuarially to try to forecast out and project as closely as possible. I'm taking a conservative approach at that as far as modeling out what is our spend trajectory going to look like over a 5-year run. Consequently, we'd even take a longer view over a 10-year time horizon to try to figure out what could those years materialize into in years 6 through 10 as well, taking a long view. But we know within healthcare, it's very dynamic, ever changing. And, with that comes a great deal of opportunity to bring in new priorities each calendar year and pursue through RFPs in many cases new opportunities to expand or enhance what we're doing from a Medicare perspective, medical perspective, as well as across the full benefit spectrum. On the medical side alone, we saw a really nice opportunity when we think about direct contracting to try to flatten the trend on spend, right? So,
Mhm.
what I think most employers probably have experienced over the last 20 years is just this incremental increase in the cost of healthcare, and medical is a key factor in that. So, if we could tamp down what that year over year trend on spend is looking like, our thesis was if we could work directly with those medical system providers where we had critical mass, that was one maybe blunt instrument to focus on quality and value, and ultimately that'll drive into greater financial performance with what we're doing as an organization, and for the good of our members too.
That makes sense. I have to wonder, in particular while you're at Boeing, I think Boeing even comes up in case studies in business schools and elsewhere around supply chain and supply chain management. And so it almost seemed really on brand that you were looking at hospital systems like a supply chain. I wonder, was that sort of a part of what the culture was like there?
Yeah, I mean, make no mistake about it. When we look at hospitals and the medical providers, access points of care that our members were receiving their care, we've known for quite some time there's pretty wide range of variability on quality.
Mhm.
And going hand in glove with that are the clinical outcomes and the financial outcomes, that bear out. Even going back to, the year 2000, Boeing was one of a short list of progressive employers that helped create the Leapfrog Group that was really
Right,
focusing on hospital safety. And,
right.
unfortunately, we see a ton of waste and medical errors in the medical community. And anything we can do to put the spotlight and steer towards high quality, high value, definitely was one opportunity that we saw could really pay off. But I would tell you that no matter what you do, you really have to focus foundationally on that patient member employee experience. If we can make that better tomorrow than what we've done yesterday, we're going to directionally be in the right pathway forward as far as making it easier and more transparent and more timely that can meet the needs that they may have, which is very diverse, from one, individual to another.
Yeah. I want to look a little closer about kind of the direct contracting. So, uh, in the year when that happened, and maybe it was just sort of organic. I mean, that it just sort of developed over time, but most employers have no idea anything about direct contracting with a hospital. How did you get started in that, and what might be lessons learned? I don't even know if you'd recommend other employers to look at it, but how might employers start taking some of those steps?
Yeah, I mean, first of all, it's a numbers game, and there was a
Okay.
team of leaders that were, I would say, aligned and taking a shot. And we demonstrated that over the past decade plus by constructing direct contracts with centers of excellence. We
Okay.
know that if we could steer members towards high value, high quality centers of excellence for high cost surgical procedures like hip, knee, spine, bariatric, cardiac, for example,
Okay.
odds are we're going to certainly uncover maybe originally what was a misdiagnosis or maybe a suboptimal treatment pathway that was originally recommended by the local medical team that individual is seeing, and we have seen that bear out. But more importantly, it's really ensuring that we have the right diagnosis, the right treatment, and the best team possible to take care of our people to deliver the best outcomes possible. When we think about the direct contracting beyond COEs into ACOs, accountable care organizations,
Right.
um, clearly Intel was, the trailblazer in Albuquerque,
Yeah.
and we learned a ton from what their experience was, and from there, we really had to pursue, I would say, a team not just within Boeing, but some consulting partners as well, and create a framework that we thought could be mutually beneficial, where we had critical mass. And this is the numbers game that I think is important. When you look at any market across the US, chances are they're radically different in a number of dynamics and fronts. But if you have volume that you can potentially run through the doors, access points of care of that particular ACO, at the end of the day, they have a choice as a leadership team as to whether or not they want to adopt and take this leap forward to pivot away from fee for service, which is alive and
Yeah.
well, and move to a value-based construct, a triple aim framework value-based construct, where they'll be measured against a few dozen quality metrics that may be derived from National Quality Forum, or we've certainly seen CMS take shots in this area too. And we really, I would say, tried to harness all these experiences that were relatively new at the time and nascent, and create a framework that we thought could serve our members well and also be mutually beneficial, where the system, the ACO in any given market that we pursued would ultimately realize the volume that they could potentially bring in through their doors, and see
Yeah.
that turn into actual claim utilization.
How much volume should somebody have before you think they can really start to move the needle with hospitals?
Our viewpoint was, a minimum threshold about 5,000 lives
Okay.
in a market or higher, right? So, fortunately for a large jumbo employer like us, we had multiple markets where we had, you know, uh, very large numbers of people that far
Sure.
exceeded, that 5,000 threshold. But, when you get underneath 5,000, it becomes more of a financial exercise to try to figure out, is the juice worth the squeeze, right? Are we really
Mhm.
going to create something meaningful from an ROI play, for that market with, relatively smaller pool of people, which then begs a question, does it make sense to maybe coalesce with other like-minded employers in that same market that might also be in a similar state where they have, relatively fewer employees than that 5,000 number? And, maybe
Yeah.
there's a way to construct, an effort to bring, some like-minded employers together in that manner.
So I'm imagining you're evaluating your data. You're looking at where you have a lot of people, and then in those cities and towns, I'm guessing you'd pull up claims to see where you were spending money on healthcare and what hospitals were present. You'd know that. Uh, you're probably looking over at, say, Leapfrog data or other quality sources. I'm guessing, I mean, you were a founder at Leapfrog. That seems like a great place to look first to find where the safest hospitals are. And then you realize, okay, at ABC Hospital, we'd love to have something direct with them. When you went into that, would you sort of go in and say, hey, look, it seems like we're paying 4 times Medicare here. Maybe we could get 3 times Medicare, just as a simple like, hey, let's start to try and reduce down those unit costs. And then, if you get really sophisticated, you can get into shared risk and other things like that. But I'm wondering, is this sort of how you approached it, or kind of a different way of going after the market?
Yeah, yeah. I mean, that's, in the end, that's part of the recipe for, the solution, is to, again, tamp down that escalating cost on healthcare.
Right.
And really, I think what we've seen for a long time is, and I've talked with other counterparts in, Fortune 50s, we've been focusing on cost, but we really took our eye off the ball when we think about quality.
Hmm.
I think if we pivot our focus towards quality and deliver or demand, improved outcomes from a clinical quality standpoint, that will trump all, right? In terms of bringing in the reduced waste and the reduced misdiagnosis and overtesting and unnecessary procedures that unfortunately account for about 3 out of every $10. 30% of the U.S. healthcare system has been
Yeah.
measured to be proven to be wasteful. So unfortunately, if we can do better around the quality side, and that was really the framework, right? If we can establish a mutually agreed upon set of quality drivers and metrics that we would drive accountability around, we're going to see the quality prevail in terms of producing better, not just clinical outcomes but financial outcomes as well. And I knew that with anything, you're going to learn as you go too. You need to refine and iterate over time. And every market is different. Every ACO in many ways are different. It could be based on their structure, what their footprint geographically is like. So there's a lot of factors that go in, to that, all things considered. But nonetheless, it really takes a deep commitment on both sides. And at the end of the day, there's also a need to adjudicate claims. And when you think about the mature, established vendor partners that we've had for decades, a health plan carrier makes a ton of sense. They do that every day. So,
Right.
working more, I would say, creatively with them, perhaps to serve that role to adjudicate claims, is another angle to weave into the picture. And,
Wow.
fortunately, when you think about ways to assemble these puzzle pieces to make something fly, it's going to require, I'd say, alignment in how we're going to execute and deliver something that's better. Some of
Yeah.
the things on that patient experience, going back to that, I think that's foundational. Is why wait 14 days to see a primary care doc, right? And why
Mhm.
only get 7 minutes for a primary care doc office visit? Under a fee for service model. How can we change that? How can we have an uber simple same day appointment scheduling capability where they're going to roll out, the red carpet, white glove treatment as far as taking care of you, almost like a concierge, and give you the time that you need, as opposed to just working a, volume play 7 minute primary care office visit. And then also the follow up and making sure that, everything, even from a preventative standpoint, that has not been done with that particular patient. Let's make sure that they're aware, and let's try to, make sure that we are on the right track as far as
Yeah.
everything that goes with that as well.
Man, there's a ton to unpack here. One thought that comes to mind is when essentially you mentioned that the system is only going to deliver what the customer demands, so to speak, that employers need to be asking and demanding for better quality. How do you think employers can work with the system today, maybe without having huge scale or direct contracts, to demand that the system gives better quality or better cost, either way, but how can we push the system?
Yeah, I think at the end of the day, you and I know this, and many others do as well. The employers, by and large, are the ultimate payer, right? They're paying
Right.
3, 4, 5x of Medicare rates, so they're paying a premium. And if anything, I think this is one of the most fascinating times in the healthcare industry, just because of all the evolution and changing dynamics. But the employers absolutely can demand and pursue those opportunities that are readily available, whether it's through a mature established player or an innovator. There's a range of opportunities that can enable them to make those hopes and priorities a reality.
Mm.
I think it's a tough one though, right? Because there's very deeply entrenched players in the industry that may not be willing to do something for a smaller mid-market employer, right? The
Right.
numbers just don't bear out. It's juice isn't worth the squeeze, as I mentioned earlier. So,
Mhm.
how do you coalesce and pursue those opportunities in a collaborative way that's constructive and mutually beneficial? And I think in the end, like almost any RFP exercise, when you think about your benefit supply chain, I think if anything, the employer needs to pursue what it is they want. And if they cannot find it, in maybe a certain area, perhaps there's other areas they can look at to do exactly that. Or, even partner with brilliant consultants, and that have been trailblazers in many ways, to
Yeah.
help them show them the way, as opposed to perpetuating status quo if that's not what they want.
If you could go back to yourself 10, 15 years ago as you were embarking on this process, what elements of the contracts like really worked and what elements were well intentioned. We hoped they'd work, but ended up not working or not delivering value?
You know, it's a very complex proposition when you think about bringing something like this to life. How are you going to measure? How are you going to report? How are you going to make sure that, as we would say, all the wheels on the bus stay on as it's going down the
Yeah.
street? And there's a lot of work, without a doubt, from the team that's focused on that, not just as far as selecting and awarding an ACO, but day to day operations, like and then the business results report outs, monthly, quarterly, semi-annually, annually. How are we seeing things materialize over time that can enable us to get ahead of the curve, as far as making some refinements or improvements where we might fall short. But I think, in short, Lee, there's a range of complexity which I think is challenging for some, but we have seen a number of other Fortune 100 employers take their own respective shots in Michigan and Florida and California and other markets with ACOs that were like-minded. And I applaud all of them, because I think in the end what they're seeing is an opportunity to pivot away from a
Yeah.
fee-for-service model, which doesn't make a lot of sense in a lot of ways, to a value-based model that is driving that accountability. So, some of the things that we really saw is member satisfaction. We
Okay.
saw a noticeable improvement with that patient experience. Year one, it was off the charts, way better than what we would traditionally be accustomed to when we think about our usual experience going to see a primary care doc, for example.
So,
So I think some of those, there's financial elements and non-financial elements, but at the end of the day, it all kind of goes back to that employee patient member experience. If we can, absolutely improve that experience, we're all about offering choice as well, as far as a
okay,
fact.
this is I have to pull this thread a little further. So
Yeah.
you're saying that you put in sort of a direct contract kind of, hey, we're going to use this hospital system plan design, which meant steering members maybe to a new hospital that's not closer to their homes in some cases, or to a different doctor perhaps. Uh, and then you also in the same breath said that this was a much better member experience. That's almost like telling me that black licorice is better than red. This is really exciting. How in the world did you design this so that people didn't hate it?
Yeah. So part of it, again, was offering choice. They didn't have to take an ACO option if they did not want.
Okay.
And, we offered it in a high deductible health plan design as well as a PPO plan design as well. But we offered incentives that would be attractive from a financial standpoint to the member. So again, this goes back to the financial elements and the non financial elements. When you think about the
Right.
financial elements, what if we offer free primary care office visits? What if we offer free generic medications? Right? What if we
Yeah.
offer same day appointment scheduling or next day, whatever's convenient for you? What if we, take off the table a 7-minute primary care office visit, which is pretty tried and true in the healthcare system today? And what if we
Sure.
offered, as long as it takes? You know, I would even go a step further. And there was a point in time where I was trying to reimagine, mental health, behavioral health, and what
Right.
are we going to do about making that better, more accessible, affordable, and mitigating, risk on stigma. And some of the ideas that we're swirling is how could we weave in at least a depression screening in concert with that primary care office visit? Because mental health
Absolutely.
and physical health are two sides of the same coin. And if we're not taking care of the whole person, we're missing the boat. So, not all healthcare systems are equipped to do exactly that. But I mean, that was kind of the vision, way back in 2015 when we were trying to think about how
Absolutely.
can we take care of people in a bigger, better way, whether it's in person or virtual with maybe a licensed therapist or mental health coach, that could help them around anxiety, depression if they have a need, or at least show them where to go and how to get access so they don't have to wait 35 days to see
So you'd
somebody
give
in their
these
local community.
you'd give everybody a choice. So, hey, here's a plan design. It is narrower, but you don't have to take it. Then, if you do take it, here's exactly where you're going to go. Oh, and also, we're going to make it, free and accessible to get into primary care. We're going to have better primary care, longer visits, and more holistic, including the mental health piece as well as the physical. Uh, Free generic meds. All of these sound like terrific perks. So it seems like the patient could kind of have a good idea of what all the valuable elements are before they went into it, and so you didn't have any uprisings around narrowing a network.
Correct. Yeah. And the other thing that I thought was pretty, important as a team, it was a great idea. What if we ratchet a higher contribution to a health savings account if they're in an ACO high
Okay.
deductible health plan option? This would be an employer, contribution that'd be higher than what we were doing just, for the plain vanilla high deductible health plan. So that was real money, right? That would be socked away. Or if they're in a ACO PPO plan design option, what if we lower their monthly premium plan contribution that they're paying out of pocket being that plan, right?
Sure.
It's real dollar savings. And, at the end of the day, this could equate to, based on individual versus family coverage, it could equate to, maybe 500 or 1,000 or more dollars in real savings, right? And that's going to vary a
Yeah.
bit based on, what's their experience, what's their utilization with medical. Like, do we have somebody that's in a polychronic state with multiple chronic health conditions and they have multiple doctors as part of their medical team, and can they access and get all that through the ACO? Or you know distance is another factor, right? I mean, maybe it's
Yep.
not convenient and
Want to
it's
be
too
close.
far, so that doesn't work for me, and I'm just going to stick with what I got, and that's totally cool too. But it's just trying to layer in some of these carrots or incentives to just help people understand that there's a real opportunity, not just financially, but also with the experience we're trying to improve over time with these partners.
A lot of people don't necessarily find huge savings in direct contracting. Um, why do you think that is? What are the reasons behind that? And it may be that in some direct contracts you're not trying to save money, but most of the employers with whom I speak are, and they don't necessarily materialize. And I was wondering if you could give us an insider's view on that.
Yeah, if you trace back to, I want to say it might have been around 2018 or so, in the USA, there was north of 600 different ACO constructs coast to coast, and it was a mixed bag. There were some that were successful and some not so successful at all. So,
Yeah.
if anything, I think it was maybe a north star to help guide us on. All right, for that cohort that are doing well, what are they doing well? What's going on there? And then for the others that are not, maybe it's the construct. There could be a myriad of factors, but really at the end of the day, each market, each ACO, each construct with what you're bringing together, certainly may vary a bit, based on the dynamics of that market and what the willingness is, right, for that system, that ACO to make that leap and commit to as well. The value, though, I really think is, really born into focusing away from fee for service, and really putting the accountability on quality. And if we can measure that and do that better, again, that's really going to be, along with the member experience, it's going to be foundational, right, with how we raise the bar on everything
Mhm.
we're doing together. I think there was a lot of learnings over the years, and they still continue to this day. Certainly within the direct contracted ACOs, and the COEs, as well, have, I would say, been a good success story when you look at the savings derived from avoiding those unnecessary high cost surgical procedures,
Right.
where that COE had the clinical rigor to maybe render a expert second opinion on the diagnosis and the treatment pathway and say, hey, Jason, this isn't the right surgery for you. Let's, take
Mhm.
care of XYZ over here. And these are some alternatives that might be more prudent and clinically appropriate at this time for you.
Makes perfect sense. I want to pivot to something that I've run into recently in some of our some different conversations around sort of a grass is greener effect. When I speak to small employers, they think, "Oh, Lee, you're interviewing, the largest employers on the planet. They spend billions on healthcare, so they can do all this interesting stuff, and they can bully a carrier, and they can get special exceptions, and all the little guys can't achieve that. But then I speak to the large employers and they're like, oh man, I've got all this red tape, bureaucracy, and lawyers. I'm swimming in an ocean of lawyers. And these little companies, they can move so fast, and it's funny, everybody's looking at the other side. I wanted to ask you the question, what were some of the items of which you were jealous of small employers that you thought, oh my gosh, I could get this done so much faster if I were, if I were a small employer?
Yeah, I think that's one. It's the velocity or speed to
Yeah.
action, right? I mean, the large complex organization, it might take months, based on, obtaining, all the approvals that are well intended, right? But there's a process. And, I think with, perhaps a smaller, employer, maybe have less, of the hoops to jump through. And maybe it's just a different construct. I think again, it's a great call out because on the flip side, I even saw this within Midwest Business Group on Health over the years, which has a mix of small, mid market, and large jumbo employers. And
Yeah.
I'd hear the same thing from the small mid market employers. Oh, you're with so and so, you're special, you can get anything you want, and it's like, well,
Right.
it's not always the case. But on the flip side, I'm really enamored with some of these trailblazers on the small mid market side as well, because there are some really great companies that are doing some really cool, innovative stuff. And, I've been privileged to meet some of them over the years as well and learn from them too. So I think, if anything, it's just, opening your mind to really all stakeholders and even from the employer market, all sizes, as far as what's working for them and how can I maybe
Mhm.
take a chapter out of their playbook and plug it in and play it with what I'm trying to solve for, within, where I'm at.
Which strategies that you were able to use and benefit from at Boeing and AT&T as well would apply well to smaller employers, things that they ought to be doing right now, for instance?
Yeah, I mean, if we think for a second about what's the highest utilized benefit that any employer offers, it's going to be pharmacy.
Right?
And when we think about the PBM landscape, any size employer can take a leap and pursue what they want in regards to their pharmacy spend and the retail pharmacies, and having the right to customize their formulary, and maybe look at ways to remove some egregious or excessively priced products from their formulary and have a waste-free formulary, at least
Mm.
aspirationally, right? But try to drive a better trend on spend on the pharmacy front too. And there's a lot of creativity that any size employer could take full advantage of if they pursue it and do it in the right way. I think part of the equation is having someone you can trust that is independent and objective and has a track record of experience of showing the way with other clients, of maybe deviating from the status quo or looking at fresh new ways. There's a line that I love. It's if if not now, then when, and if not me, then who. And when I think about if not now,
Mm.
then when, and if not me, then who, now is a great time as far as constructing what you want when you think about the pharmacy spend, but also identifying the consultants that have done that, as opposed to maybe just perpetuating misaligned incentives that have plagued the industry for far too long. So there's a lot to unpack there as well, Lee, when you think about,
Yeah.
do I have a trustworthy consultant or broker that is looking out for my best interests, almost like a fiduciary in a lot of ways? And then on the financial side of things, and then how can I weave that into the construct that I want, beginning with the end in mind, right? So do I want to just continue to pay whatever I'm paying year over year with those annual cost increases on my pharmacy spend, or do I want to have more capabilities to, again, just like the medical example, tamp down the trend on spend? My aspirational goal with any benefit supply chain was to try to identify a way to get to a negative trend on spend year over year. And if I fall short, maybe it's a flat trend on spend, but I'll tell you what, that's going to be far better than, what the national average is for employers. And,
Absolutely.
when we look at every penny saved, um, in terms of real dollar savings, that, for a large jumbo, that could equate to $100 million in
Oh yeah.
savings. So if I save,
So
let's say $600 million, that's like 6 pennies on earnings per share. When we think about how does this draw back to the bottom line and correlate to Wall Street, as far as a
yeah.
P&L game that I'm actually working on as a company for just benefits healthcare alone, just based on the vast sums that we're dealing with.
I want to push on that of okay, so if I'm a benefits manager and I'm looking at the different elements of spend, my goal is to get to flat trend, and I totally agree with that. Many people feel like either that's unreasonable or unattainable. Maybe take us under your wing for a minute and coach us tactically on how we can get flat trend in a couple of areas right now.
Yeah. One thing that worked really well for me over the years was having a competitive bid RFP process.
Okay.
And really,
Now
not
everybody
just
does that, and we don't necessarily get great results, so you've gotta be doing it in a special way. Give us the
correct.
details.
Yeah, that's exactly. So if you're just doing RFP to do an RFP, and maybe you switch a vendor or maybe you don't, that may not really bear much fruit in terms of savings. It might be incremental savings, but it's not gonna, really fall off
That's
the
right.
cliff in terms of savings. So that's really where, whether it's medical or pharmacy or dental or vision, we've had experience, over the past decade plus around ways to take full advantage of identifying upfront what it is you want to solve for. On the PBM side, I was looking at non-financial elements as well as financial elements. Maybe I
Okay.
should move away from traditional spread pricing, go to acquisition cost plus that's fully transparent and gives me complete command and control, to contract and partner with whoever I want, anytime, any reason, as well as auditing firms, all that kind of stuff. Right? Those are I'd say a sandbox of non-financial elements that I can define and create my own terms and conditions, and as well as define what's the definition of a rebate. I mean, those are all things that one can do, right? And then when you think about the financial exercise, sometimes it can become a spreadsheet analytical exercise where
Mhm.
it's in some ways maybe a bit outdated as far as what's really going on today in 2023 versus where we're at in 2013 with some of these different
Sure.
opportunities. I think the other thing is when you look at maybe modernizing your benefit, maybe you have a broad-based network across the U.S. with your retail pharmacy network, or maybe your vision plan network. Could get anchored down with some high value, partners that really focus on lowest unit net cost. And we see a lot of variability in cost and margin, certainly in the optical field when we look at what's going on there. So, how can we take full advantage of, I would say, on unlocking and uncapping that value in the form of the RFP, and ultimately select, that vendor partner that is going to align with you entirely without deviation, and give you the green light, and you get that golden coin, Lee. You're going to
Yeah.
get to move forward with exactly what you want, and we're not going to get in your way. And on top of it, we're going to give you rock bottom, admin fees, and everything else that is pretty typical in the industry. But the whole point is, I want my supply chain to be solvent and to be healthy and to be around. So you
Right.
want something that's fair and reasonable. But at the end of the day, I think it's attacking, what are those, I would say misaligned, incentives, perverse incentives that are in the industry. How can we remove that? How can we get rid of the waste? And, part of that is, again, going into the detail on the non-financial elements, and, establishing, this is my sandbox. This is how we're going to function, go forward. And if you want to participate, let's do this. But if you don't, no harm, no foul. We'll try to find
Mhm.
someone else.
This is interesting. So now let's pivot a little bit to medical. Say I'm an employer, I'm gonna go out to do an RFP. Uh, I'm a modest, maybe mid-market size. and I'm going out to medical RFP, what are the three things that I need to be getting in that RFP in order to start improving my position?
Yeah. So first of all, it's always going to boil down to two key things, right? What's the financial value prop, and how does that compare from my current state to my future state, right? What's the net of this thing going to look
Right.
like? And there's a number of things I can weave in, like maybe there's a way I can, establish, some financial language around, fees at risk and service level agreements, and in some lines of business, maybe rate guarantees, that would be a fixed rate guarantee. But, as far as, the financial side of the equation, that is going to be essential, right? To really have, clarity on that. On the non-financial side, um, what's that partnership really going to look like from a employee experience, right? What kind of disruption am I potentially facing if I were to switch from one vendor to another? Am I improving or reducing my network and access points of care on the medical side? Those are tough calls, and important analytical points to understand from that employee experience standpoint. How is that going to change when we think about transition, vendor transition, and change management and communications? Is this a good thing or a bad thing? Is it a plus or a minus in the eyes of the people that we're looking out for, and it's our employees and their families? So, anything we can do to raise the bar and making their experience better, quality, and lower cost, and a better member experience. I think, if we would take a triple aim, I would take a triple aim value based framework to everything. And one thing that I stole shamelessly from my friends at Google years ago was they would call it the three E's. And it's, the experience, which is predicated on the member, the effectiveness predicated on clinical quality, and efficiency. What's the financial ROI? If we can check those three boxes off directionally in the right direction on the three E's:
I love that.
experience, effectiveness, and efficiency, we know that more often than not, we're definitely on the right pathway forward. So whether it's medical, PBM, dental, vision, some new health tech innovator startup, if we can make all that directionally better, we're going to be in a really good place.
What were the main KPIs that you would look at to know if your health plan was doing well?
Yeah, it varied. I mean, we had a number of KPIs, from the medical side, like when we were talking about, ACO side of things, that was all really heavy on quality metrics, right? Because we're trying
Okay.
to improve quality and, deliver a better experience and outcomes all around clinical quality. And that's going to bear out into the financial bottom line if we do it right. When we think about pharmacy, we had literally dozens and dozens of slides that we would review every quarter. But even in between our quarterly business reviews, we had the right to look at our formulary and make tough decisions on what do we modify as far as coverage or no coverage. And it's a timely topic today with the GLP-1s, anti-obesity medications, right? You got two schools of thought, like these cost a lot, but they show great promise. And then maybe we still consider it a lifestyle drug and just don't cover it at all. So it's a
Right.
whole nother conversation. But it's thinking through, like, what are the implications, not just clinically, but also financially. And some of the stuff that we would try to weave into this is on the KPI front is reasonable metrics that were not just embedded with what we did every year, but we would look at ways to try to bring in new KPIs and update and modernize that as well. Especially if we did an RFP, we're looking perhaps at a whole new slew of KPIs based on the construct of a new program that we're looking to scale up.
Hmm.
So I mean, it's some of it, might be more of a planning exercise to figure out where are we falling short on a KPI front. What can we make up to shore that up, and how can we mitigate risk as well, which is always a key consideration with anything we do. On the vendor supply chain side of things.
Yeah. What are the biggest mistakes that employers are making today that, man, if we could just turn those around, we could really move the industry forward?
Yeah, it's probably three key areas. Really hammering down on medical and pharmacy because that accounts for over 80% of most employers' healthcare spend every year. And there's a lot of opportunity on those fronts. Um, we're seeing a lot of movement towards advanced primary care, which is really interesting, and I think it bodes well for everyday patients. Um, on the health tech innovator side, we've seen a ton of innovators over the last decade, thousands, in fact, that sprouted up in very wide-ranging clinical categories, and I think that there is a real play, long term, with virtual solutions that can arguably deliver, and even based on their peer-reviewed journal articles and white papers and case studies, demonstrate superior evidence-based outcomes to meet anyone, anywhere, anytime, regardless of zip code and lack of access to medical or food or whatever the case might be. When we think about social determinants on health and DE and I, how can we make sure that no one is left behind from a healthcare perspective? And that's
Yeah.
the real play. I think as we look ahead over the next 20 years, you're going to see more convergence of what we're doing from a virtual play into the traditional play. I think there's a lot of fragmentation and silos in a lot of ways, unfortunately, and data interoperability that's opportunistic that can all come together much better and cleaner. So there's much, I would say, on the path forward that I'm excited about that can really drive impact. But we still have a ways to go. I mean, in real life, if you have a patient that is going to a primary care doc, maybe an OBGYN, maybe a psychiatrist, they might have multiple prescriptions from three different sources, maybe four.
Sure.
And oftentimes they have no idea what's being prescribed and what's going on for that patient because they're working in a fragmented, siloed state in many cases. So how can we ensure that we're bringing this all together? And I think that's really what's exciting about a lot of the innovators that I'm seeing. They're taking steps forward to do exactly that, to integrate that holistic care all together.
That's interesting. Where do you see the biggest opportunity right now that's getting too overlooked for employers to improve cost or quality?
Yeah, it's a great one. I have concerns on a few different areas. Certainly mental health has been top of mind for the last 4+ years for many. The pandemic exacerbated that, and we still have a ways to go when we think about how can we do better around that front for all people, regardless of age. When we think about obesity and cardiometabolic health syndrome, by 2030, it's projected that 50% of America will be technically classified as obese. So think of the trillions of dollars of spend that will be going towards that clinical category. Right now, today, we're at about 42% of the USA that's obese or overweight. So we have a lot of opportunity to try to help people live a better quality of life through behavior change and doing a
Mhm.
ton of things in that area. And then when we think about the correlation of those two big areas of opportunity, my simplistic view is, and this goes back to like 2015, right? When we were talking about, what if we were to weave in a depression screening with a primary care office visit? Or what if we were able to bring solutions forward that could take care of the whole person? There's a real play when we think about helping employers and helping patients not be left behind, get
Mhm.
access, improve affordability. We have 100 million Americans that are grappling with medical debt today.
Mm.
53%, bypassed getting a prescription medication filled last year because they had
Mhm.
made a tough choice to, maybe put food on the table or pay their rent.
Yeah.
So, affordability is a huge issue. Accessibility is a huge issue. Stigma, certainly on the behavioral health side, is still a tough issue. Over 100,000 opioid deaths, last year for the first time. We've seen the life expectancy rates decline in recent years in the USA.
Yeah.
And we're grappling with north of a $4 trillion annual healthcare spend in the US and 11 trillion globally. and that's accounting for roughly 20% of our GDP. So no one in
Yeah.
sight. It keeps going higher. And I remember, when it was 3.6 trillion. So here we are, around 4.2 trillion, and it just
Yeah.
keeps going higher. So we have to figure out how to, I would say, collectively, as thought leaders and employers and beyond, really take some shots to bend that trend for the good of our people. I mean, if anything,
Absolutely.
we got a real opportunity to do more.
I think that's a great kind of message of hope to finish on. That's what we're here for, is to try and improve the way the system works using our benefits and healthcare plans to be able to get there. Uh, Jason, thanks so much for joining us today. Thank you all for listening. If you found today's meeting helpful, feel free to connect with Jason uh, over on LinkedIn as a way to reach out to him if they want to continue to interact, and feel free to send today's episode to any friends or connections who might be able to learn from it as well. And thanks for joining us on Broken Benefits. Thanks for joining us on Broken Benefits. If you enjoyed today's episode, please subscribe to our YouTube channel or on your favorite podcasting platform. Also, please share today's show with a friend or colleague. It's free to do, and it helps us spread the message to as many people as possible.